Hi, my name is Gretchen McNally. I'm a nurse practitioner scientist at the Ohio State University James Cancer Hospital. This is a new position for me. I really started it in September of last year, 2024. I've been a nurse practitioner in hematology for 18 years, and I've been working in an immunodeficiency cancer clinic for over a decade now. I became really interested in people with substance use disorders, not only those with like HIV, for example, which is a population I'm passionate about, but in general. And that kind of took me to addiction-related stigma. Addiction is one of the most highly stigmatized conditions. And so because of my population of interest, people living with HIV also experience a lot of stigma. I decided to work on my master's in public health, which I graduated in August of 2024. So during that process, I was really fortunate to do a deep dive into stigma. Ellen Carr, who is the former editor of the Clinical Journal of Oncology Nursing, CJON, actually had reached out to me about a project related to palliative medicine and stigma, because a lot of people confuse my interest in addiction with palliative medicine, which are really not the same. But anyways, we were talking, she got this great idea to do this deep dive into cancer-related stigma. So that is how I really started, and it was fascinating. So that kind of fast forward through my MPH, where I was able to further focus on that. I worked on really hard to become a national expert on stigma related to cancer, intersectional stigma. And so I was fortunate enough to have ONS invite me to discuss cancer-related stigma. But I worked with some colleagues and we did a presentation on intersectional stigma, starting with a case study. Then I talked more about the background of stigma, why it's a problem. And then Carrie Ramirez from City of Hope talked about stigma related to palliative medicine, opioids, and hospice. And then we kind of summed it up by talking about what we can do as oncology nurses to reduce stigma for our patients. Stigma is a huge barrier to care. And the National Cancer Institute actually recognized stigma as a huge barrier. They did an international workshop in 2022 with people. It was virtual meeting from across the globe to kind of discuss the different issues. And earlier, before that, in 2019, the BMC did a really nice series on stigma. And the thought was that stigma, so if I apply it to the cancer continuum, so for diagnosis, people might be ashamed or they might have a stigma of cancer in general, let alone specific cancers are more highly stigmatized. So they may associate cancer with like dying. So they don't want to present for diagnosis or they're afraid their symptoms. That's if they have like perceived stigma or public, what they think is public stigma. People like clinicians can have stigma. So maybe someone presents for care with HIV, for example, and they don't want to offer them the standard of care screenings or they're denied care. And then you have that kind of prevention leading up to diagnosis. When you get a cancer diagnosis, there's a lot of stigma, especially, again, depending on the cancer, but any cancer type. And a lot of that comes from like your own personal background, your family, what you get from the media, where you live, like geographically, your culture, all kinds of things. It's really important to realize that stigma is like so complex. And it's multi-level. And so it's really hard to understand that until you like dive deep into it. But so it can prevent people or is a barrier to people receiving care. People might think that, the outcome's going to be poor, I'm going to die, so they may stop care even though, or treatment. They may then going into survivorship. They may be have job discrimination. Their employer may fire them. They may not be eligible for promotion, and other things like that. And then, of course, palliative medicine kind of encompasses all of that, which has all kinds of barriers associated with stigma related to that. By starting to use like standardized instruments to measure stigma that we can compare across conditions, and just getting a better research base. Lung cancer, for example, has a lot of stigma associated with cigarette smoking, even though not all lung cancer is caused by cigarette smoking. So there's been a lot of work in that area. I think looking at other areas and borrowing from them, mental illness, depression, they've done a lot of work in the stigma world. HIV has done a lot. That doesn't mean those things aren't still stigmatized, but we can borrow from them. And I think that that's really where there's a gap and an opportunity to move forward. You often hear, but they have lung cancer, but they smoked or whatever, they drank, they didn't take care of themselves. So you have that but, and that but almost like makes it okay. But is it okay, like just because I smoke cigarettes, do I deserve lung cancer? Is that my punishment? Is it okay? Like, I think that no. I think oncology nurses should have a compassion, for everyone, regardless. Addiction is a disease. Smoking cigarettes, if you could quit, no problem, most people would, especially because it's so expensive, right? Besides all the other health reasons. So I think that that's part of the stigma with cigarette smoking. And then I think that people don't realize how outcomes have improved so much for lung cancer. And yesterday, after my session, somebody asked a great question. If I thought, because with biomarker testing, they're identifying more and more lung cancer that are in people that do not smoke, will that start to shift the stigma? And I think that it will. That will shift it. But HPV and cervical cancer, or a lot of the head and neck anal cancers, is another really highly stigmatized condition, and that's preventable with an HPV vaccine. But most people associate HPV as an STI or with sexual activity, and that's not true. So that is another area where we can really, they should eliminate or eradicate cervical cancer because it is preventable with that vaccine.